All right. So last time we actually start talking about um overall structures, right? Of the I'm gonna go really fast to review last time for the system neuroscience, right? So we spend most of the time talking about cell neuroscience. That means how action potential is developed, how it's, travel and then activate the next neuron or the target cells, right? We also start talking a little bit about the system neuroscience, right? And talk about, major structures, which include central nervous system and peripheral nervous system, right? So, and hopefully, central nervous system has brain and spinal cord, and then peripheral nervous system has, cranial nerves and spinal nerves, right? And today we will see more detail on these spinal nerves because it include sensory nerves and motor nerves. Structure of the brain, we mentioned a little bit of these structures already, and then we talk about the major, lobes in our brain. When we go through each of the system, we will zoom in and then you will learn more about each of these area of the brain. Okay. Thalamus, make sure that you remember, right? Thalamus is kind of like a center for sensory information, right? Gatekeeper or basically transit stations, all the sensory information will travel and then synapse or connect at the thalamus before the signal go to the final target in the cortex area, right? And brainstem's connections between the brain and spinal cords, right? And it include midbrain, pons, and medulla. It also play a lot of roles in, very important roles in your body as well. Spinal cord, we talk about this, right? We have C, T and L and S, right? So different section of the spinal cords. And then when you zoom in to the spinal cord, we have the nerve that are going into the spinal cord, right? So those are sensory nerves, right? So you will see more today. Sensory nerve coming from, your skin, your muscle, your joint, right? That detects sensory from the body and then go travel into the spinal cord, right? And then from spinal cord, of course, it's go up to the brain. Oops. Okay. In contrast, we will also learn today that there are another nerve, right? Motor nerve that coming out from the spinal cord, right? Spinal cord coming out and then go to the target muscle. So that is in the motor system. Okay, so remember the spinal cord, right? So we start talking about somatosensory system, which is the system that you detect sensation from the body, right? Now when you think about body, it can be either skin, it can be either muscle, right? Or internal organ as well, or even joint, right? So you have sensation. And the three major components of the somatosensory system, if you remember, you need sensory receptors, right? And then you need the pathways. That's why we stopped last time, the pathway of, somatosensory system. And then finally, you need the center in the brain, right? Without all of these three, if you're missing any of these, you cannot sense the sensation from the body, right? And then we talk about receptors, right? We know, the term exteroreceptors, which are the receptor on the skin, right? Which include several types of receptors. You have proprioceptors, right? Make sure you know this term, proprioceptors. That means the receptors um, that detect the movement, the joint positions, right? And those receptors are located in the muscle, tendon, or joint, right? You also have the receptors inside the internal organ, right? So you call enteroreceptors, right, in the viscera. And for example, it detect the movement of your gut and pH of your blood as well. So this is based on locations, right? If you characterize receptor based on, how it's activated, then you have chemoreceptors, photoreceptor, thermoreceptor, mechanoreceptor, and nociceptor. We talked about this last time, okay? And we talk about different types of skin receptor too, right? So, Pacinian, corpuscle detect vibrations, right? And these hair follicle detect light touch, and the deep one, Ruffini ending, detect deep pressure, sustained pressure, for example, okay? Now, again, see, proprioceptors are the one that detect, right, mechanical force and pressure, the movement of your body, for example. So every time you contract the muscle, right, the muscle contract, it will activate receptor inside. And this receptor is called muscle spindles, right? So the receptor inside the muscle that detect the contractions of the muscle stretch, the stretching or contractions of the muscle spindle. Okay, detect the muscle length. When the muscle length change, right? Then muscle spindle is activated. Okay. You have also Golgi tendon organ, which detect the tensions in the muscle tendon junctions, right? And joint receptors composed of different types of receptor, and again detect information about pressure that you get you press onto the joint, right? The position of the joint, or the receptor, including pain receptor as well, right? And we talk about the property, 2-point discrimination, ability to differentiate between the 2 points, right? Pain, we talk a little bit about pain, and we know that it's important sensations, right? And we know that there are 2 types based on the quality of the pains, fast pain or slow pain, right? Fast pain, for example, you feel like sharp, pricking, acute electric pain, that first pain that you feel, those pains are the signal that are delivered that are propagate in the neurons, and very fast, because that neurons are a delta fiber. Okay, so a delta fiber are small myelinated fibers, which is like super fast, right? So when you have myelin signal, propagate or travel very fast, right? So that's first pain. The other type is slow pain. So those are the unmyelinated fiber, so no myelin, right? So this is called C fiber, okay? So it's deliver slow pain. So it's kind of aching, chronic, or even refer pain, right? So this is different types of pain, right? Now, continue where we left off last time. So you have different types of receptors, right? And after you stimulate the receptors, that receptor is stimulated, the action potential is developed, right? And those action potential is then travel along the nerve, right? Along this axon, and then arrive at the spinal cord, right? So again, if you look at these pictures right here, you will see this is sensory neurons, right? So the cell body of the sensory neuron is located here. And then at the tips, it become like a special structures and become receptors that we talk about, right? On the skins, right? And so after the receptor is activated, both we have 2 major tracks, right? That will bring up the sensory sensation up to the brain. Okay. So the first track here, you can see that it comes into the spinal cord, right? The blue one here represent the first order neurons. Okay. So when it arrives at the spinal cord on one side, it goes up on the same side, right? It's go up on the same side. And then once it's rich, medulla, right? Medulla, which is a part of the brain stem, if you remember, it synapse or connect to the second order neurons, meaning the second set of neurons, right? In the medulla. So in represent in red right here, right? So once it's connect, now the interesting thing happened. This second neurons cross to another side, right? So the cell body is here, right? So we learn about synaptic transmission already. That's what happened here, right? So the end axon terminal of the first neuron connect with the cell body of the second neurons, right? Hold on a second. Yeah, so, and then second neuron there, then cross to the other side and then go up to, what is it here? Thalamus, right? So again, this is first example to show you that the thalamus is basically a gateway to the cortex, right? Because the sensation from the body have to connect here at the thalamus first, right? Gatekeeper. Okay, so the last one, the last set of the neurons come out from thalamus and then send the axon to the final target on the brain, which is somatosensory cortex. Okay, somatosensory cortex. So this is the first track, right? Now, these first tracks are usually the track that deliver the feeling, the touch, pressure, and vibrations. Okay, mainly mechanosensory sensations, right? Anything pressure, right? Touch, pressure, or vibrations using this track. Okay. Another tracks, similar idea where you have one, two, three neurons, right? Three sets of neurons. However, the difference is where the neurons synapse, the first and second neuron synapse and cross to the other side, right? In this case, these tracks deliver the pain sensation and temperature sensations, right? So, oops, hold on. Okay, so let's say you have some pain sensation or thermal sensation. Similar idea, those receptors will be activated, right? And an action potential travel through the first neurons, right? Arrive at the spinal cord, okay? In this case, instead of going up to the medulla like the previous track, it synapse right away, right? In the spinal cord, synapse first, right? So it's connect to the second order neuron first. And then second order neurons cross to the other side of the spinal cord and then go up to the thalamus. Okay. And from the thalamus, again, another set, the third set, the final set of neurons go from thalamus and arrive at somatosensory cortex. Okay. So nothing to memorize in detail in these slides, like no names. If you learn anatomy already, you probably know the name of these two track, spinothalamic tract versus another tracks, right? But in this case, I just want you to appreciate that, oh, when you talk about sensation from the body, you kind of differentiate between two types of feeling, two major feelings, right? Pain, temperature tracks, and touch, pressure, vibration tracks, okay? That's all, right? And appreciate that you need basically three major sets of neurons before, that goes from the body up into the somatosensory cortex, okay? All right. Now, and it's useful also because sometimes, when you have like injury at different levels, sometimes when you test for pain or you test for touch or pressure, and it can help you to identify, which track is having problems, okay, based on the result for that sensation. Now, once those tracks reach the final destination, which is in the brain, right? So those brain area is called somatosensory area or somatosensory cortex, okay? And it's located behind the big, we will emphasize a little bit more later about the anatomy device, right? But for now, just know the name somatosensory area in the cortex, right? In this area, okay? Now, when you look at this diagram right here, it just shows that in this somatosensory cortex here, if you cut this and then, open it up like this, you will see along this somatosensory cortex, you have the map, right? You have the map. For example, this area, it's dedicated for fingers, right? So each of the fingers, right? It's a huge, right? This is the areas, this is the brain that, detect the hand areas, right? And this is the areas that detects forearm, for example, okay? Now question is, and look at the face. The face is big, right? And the areas that dedicate to receive information from lips is also big, right? Also the thumb, or the nose, the face is huge, right? Compared to other areas like arm, shoulder, head, neck, it's very small, right? Can anyone tell me why? Why do you have such a big areas in the brain for the face, the lips, the fingers?
Maybe because those organs have to perform precise motor function.
Okay, good thinking. But what are we talking now? Mm, what are we talking?
Oh, sensory. Mhm.
Sensory, right? Yeah. So similar idea, very good answer. But think about the other hand, the other end, right? It will be the same in motors area, but in this case, it's sensory, right? So say again, try again. This area.
They need to pick up more precise sensory information.
Yeah, exactly. So more precise or more comes from more receptors, right? So as tested, we test last time, right? Using two-point discriminations, right? Fingers are able to differentiate between the 2 points, right? The touch of the 2 points, the two pens that you touch, right? Versus if you put it in the calf, the leg, the arms, you can't really differentiate those, right? So it shows that your fingers, your lips, your face has a lot of receptors, right? So those has to receive a lot of sensory information, right? So the large part of the brain are dedicated to that area. Okay, very good. All right, so now, so not only we have the map in the brain, in the spinal cord, somehow we also have like a rough map as well. And so this is called dermatome. Okay, so what exactly is dermatome? So in order to understand dermatome, we have to look back at the spinal cord first, right? And remember that each of the spinal cords, right? So the C, we have C1 to C8, right? So T thorax is, T1 to T12. Again, no need to memorize this number, but just to show you that we have different section of spinal cord, right? So each section of the spinal cord have the nerve, right? And the sensory nerve is the nerve that we receive information from the body, right? For example, C1 right here, you will have the sensory nerve that come from the areas in the body, right? In the face, usually C2s here on the head, C3 here on the back of the head, right here, C4, the neck, right? So let's say C7 is a little bit larger, right? C7 here, you can see for the arm, the whole area right here, meaning that the whatever labeled in SC7 right here, these areas of the skin will have the nerve, okay, will have the nerve that eventually go into the spinal cord at the C7 section, okay? So let's say if you touch here on the shoulder and if you touch on the finger here, even though the receptors are different, right? At the end, it will merge into the nerve that enter at the same level. Okay, so C7. Okay, And same idea, if you look at the L, the lumbar, right? So L are usually they have the nerve that coming from, down here, right? From the waist down to the leg. So if you touch somewhere on the knee, right here, okay, where is it going? Which section of the spinal cord? If you touch here.
Going to the L4.
L4, right? Very good. So L4. So this is basically the dermatomes, right? So basically area of the skin that are innervated by one single nerve, single spinal nerve, okay? And it's very useful for diagnosis. How? So let's say the patients come with spinal cord injury, right? They come with like accident and you don't know where, right? You don't know what's going on, which section of the spinal cords are, having problems. And so for somatosensory test, you can touch at different locations or test the pain sensation at different locations, right? Let's say if the patients, let's say, lost the feeling on um this finger right here. So what section of the spinal cord can be, have a high chance to get damaged or injured if the
T7.
D7, right? So it's probably somewhere, around here, right? So this is a very useful, right, knowledge to know. However, you have to keep in mind that the map will look like, this clear cut with the borderline and everything. But in reality, it can also be some overlap as well. Okay, C7 and CX is not this sharp, separation between the two. Okay, but it gives you some approximate like information. All right. Okay. So this is an example of some of the tests that we can do. This is what we did with the two pens, right? Similar idea. In reality, you use the pointy forceps to test. So you should be able to differentiate between the two point, right? By discrimination, foot touch, see if you're able to feel the light touch or not, or if you can feel vibration or not, right? Remember those tracks that deliver touch, pressure and vibrations, right? Or sometimes you have the pain, yeah, you use the pin to see if the patient can feel pain or not at all, okay? So any questions about somatosensory system before we move on to the next system? Mm. One thing I forgot actually, let's go back a little bit to, so we talk a lot about the skin, right? So here I forgot to mention this. We will discuss about this again, but I just want to emphasize that these receptors, proprioceptors, okay, the one that are in muscle, in Golgi tendon, the connection between muscle and tendon, and the joint a very important signal, okay, from the body that tells your brain how much pressure you should put, okay? For example, you want to walk, right? We will see in the motor system that when you have developed the idea of, okay, I want to walk or I want to run, right? Then the brain will send the signal down to those specific muscle, right? To the leg muscle. But then how do you know how much pressure do you need to send down, right? And in the same time, how does the brain know that, oh, the pressure that it's sent down to the muscle, the joint, the tendon, it's enough, or it's appropriate amount of pressure or amount of contraction, right? And the answer for that is because you have proprioceptors, okay? Or these muscle spindle in the muscle, Golgi tendon organ, and joint receptors. All of these receptors will send a signal back to the brain, telling the brain, okay, we have a good amount of pressure, we have a good amount of contractions, right? So it's a very important feedback information to tell your brain. And so that's why it's one of the receptors that are very important for maintain posture and balance, okay, as well. okay, and all the movement, okay, right? So, so every system is actually linked, right? So now, okay, if there's no questions, we will continue with um, motor system, okay? So in motor system, again, it's the system that we use to control the movement, right? And the key concept, key idea is it's the nerve that control muscle contractions, okay? Because any, I'm gonna move this a little bit out of my way. Okay, oops. Okay. Any muscle uh contraction or relaxation will create some kind of movement in your body. Okay. For example, if you want to lift your hand, if lift your arm, right? You have to stimulate this muscle to contract, right? So when this muscle contract, then you can lift your arm, for example. Okay. And actually they're complicated, different sets of muscle that work together to make you able to move the specific part of your body, right? But the general idea is that you have the brain, right? And then you have the signal that come down from the brain down to the spinal cord. And then from the spinal cord, you have another signal or another neurons that go directly into the muscle and create muscle contractions. Okay. And this is we call voluntary movement. Okay, why do we say voluntary? Because we think about the movement, right? So we have the part that we decide, okay, I want to move my arm. So that's why you make a plan and then you generate the signals in the motor areas, right? The motor areas in the brain now is called motor cortex, right? So the previous one is somatosensory cortex. In this case, motor cortex, right? So neurons in the motor cortex will send a very long axon down to the spinal cord. These neurons are called upper motor neurons. Okay, so the first term in motor system, upper motor neurons. It's the neurons that come from the brain, basically. Okay, and then go down to the spinal cord, right? Now, the second set of the neurons synapse with the upper motor neurons, right, in the spinal cord. So second neurons or the neurons from the spinal cord that going out, right, from the spinal cord. If you remember the first in the overall overview slides, right, there's one um nerve right here that are coming out from the spinal cord, and this nerve is called motor nerves or motor neurons, right? And this is specifically because it's from the spinal cord to the muscle. We call these lower motor neurons. Okay. So any motor neurons that connect directly to the muscle, right? So you can think of that lower motor neurons. Okay. So now hopefully you can differentiate between what's upper motor neurons and lower motor neurons. Okay. So this is a basic diagram. Now, and again, you need all of these in order to make a proper movement, right? It's basic, simple, but in detail, you will need more than that. Now, the movement, there are two major types of movement, right? So voluntary movement, we talk about it, right? When you think, when you want to do something, you intentionally think you want to move your leg, you want to move your arms, your finger, for example. But sometimes you have the involuntary movement, right? Or reflex, right? In which you move your body without even think about it, right? So the first type that is very common, everyone think about it, is when you touch the fire, for example, you move your finger away from the flat fire right away, right? Sorry, it was the die still. I forgot to change it. And so you did not spend time thinking about it, right? You did not think about, oh, the fire is so hot, let's move my finger, right? You did not do that. You immediately move your finger away without thinking, right? So that's the example of a reflex. Or another type of reflex that is very useful in clinic is the, stretch reflex. These reflex when you do the knee jerk and then you hit with the hammer here on the knee and then on the tendon below the knee, and then your leg just kicked, right? So these are example of reflex, right? So that would be the first type of movement that we would discuss because it's quite simple and it was very important diagnosis in some cases, okay, for the neurological problems. So let's say what's reflex. So any reflex movement, so we're talking about reflex movement, okay, of the muscle. The components of those reflex are sensory receptors, okay? So sensory receptors can be receptor either in the skin, in some type of reflex, for example, those pain receptors, right? When you touch fire, right? So you can stimulate those pain receptors, for example, or nociceptor, right? So, or the muscle receptors, muscle spindle, right? That's the receptor inside the muscle. Or it can be Golgi tendon, right? Muscle or Golgi tendon. Those are receptors. And then after that, you're gonna need sensory neurons, right? So we talk about that sensory neuron. So sensory neuron will bring that signal into the spinal cord, right? And in the spinal cord, there are some synapse occur inside the spinal cord in the circuit, right? And then you have the lower motor neurons, right? Remember, why do we call it lower motor neurons? Because it's coming out from the spinal cord. It's the motor neurons that coming out from the spinal cord and then connect or activate the muscle directly, okay? So last component is the effector or target muscle, okay? And then you read to the response, right? So again, component sensory receptors, right? Sensory neurons, motor neurons, more specifically lower motor neurons, and then the target muscle, okay? There's no brain involved in this circuit, okay? This basic circuit, or another term of reflex component or reflex circuit is called reflex arc, okay? So just this component, right? A little bit of detail, okay, before we go into a specific example. When we talk about spinal cord, so what happened inside the spinal cord, okay? So when you have the sensory neurons, this is the sensory neurons, right, that are delivering sensation coming into the spinal cord, right? And then another purple one right here is motor neurons, right, going out in between the two neurons, okay, between sensory and motor neurons, you can have the neurons that called interneurons, okay? And you can have one neurons or you can have two interneurons in between, okay? Depend. This diagram is just a simple diagram showing just one interneurons in this case, right? One interneuron. And another thing to keep in mind, the interneuron can be both excitatory interneurons, okay? That means if this neuron is excited, it's going to release the neurotransmitter that excite another neurons. In this case, it's going to excite the motor neurons, okay? But you can also have another neurons, interneurons, that are inhibitory interneuron as well. If this guy is an inhibitory interneuron, that means when you activate this guy, it's going to release the neurotransmitter that will inhibit the function of these motor neurons. Okay, so keep in mind that when we talk about interneurons, we know whether it's excitatory or inhibitory interneurons. Okay, all right, so this is again reflex arc. Now let's look at the example of the first type of reflex, okay? So this type of reflex is called stretch reflex, okay? Stretch reflex. And one of the common example are the deep tendon reflex, okay? And it can be different locations. Sometimes you can test this in a bicep, triceps, right? But for the leg, the most common one is called the knee jerk, okay? So what happened here is you tap the patella tendons, right? The tendons right around in front of your kneecap right here is called patella tendon right here. When you tap onto this tendon, it's gonna cause this muscle right here to stretch, right? Quick stretch from the tapping of the tendon. That stretch of this muscle will activate the receptor inside. And if you remember, the receptor is called muscle spindle, right? So muscle spindle will detect that stretching of the muscle and then send the signal through the sensory neurons, right? Arrive in the spinal cord, okay? The first thing that happened is here you have the direct synapse, right? Between the sensory neurons and the motor neurons, right? Those first motor neurons will go directly into the same muscle that were stretched before, right? And then now when you activate sensory neurons here, it's going to activate the motor neurons that go back. So when you activate the motor neurons that go back, anyone remember neurotransmitter inside the motor neurons? Neurotransmitter that is used at the muscle. What kind of neurotransmitter? We mentioned that a little bit. Anyone remember the
Is it
type? Mhm.
Uh, Acetylcholine.
Yes, right? ACH, acetylcholine, right? Very good. So these lower motor neurons will release that acetylcholine, right? And then cause the muscle to contract, right? So probably, hopefully you learn this in physiology, right? A little bit. So after, when these muscle contract, it's gonna pull the tendon up, right? So that's why you can, as a result, you kick your leg up, right? So imagine this muscle contract, from this reflex action. Then you pull the tendon up, then you kick the leg, right? In the same time, you not only have like one group of muscle, right, in the leg, you have also the opposite muscle, okay? In this case, the muscle on top that were stretched in the beginning after the tapping is the quadricep, right? The opposite muscle is the hamstring, okay? So imagine if you want a response by kicking the leg out, how do you have to do? What's the hamstring has to be? Contract or relax?
they have to be relaxed?
It has to be relaxed, right? Because if it's contract, it's gonna like fight each other, right? So if both relax, nothing's gonna happen. So one contract, the opposite one has to be relaxed, right? In this case. So how do you make the second one relax? So in this reflex, you see a second branch of the sensory neurons right here, right? And number two right here. It's synapse to an interneuron, okay? And these interneurons is inhibitory interneurons. And as a result, it's going to inhibit the lower motor neurons that go to the hamstring, okay, or the opposite muscle, to inhibit this action of the lower motor neuron to the hamstring. And that's as a result, the hamstring is now relaxed, okay? So we can call these opposite muscle antagonistic muscle as well. Okay, so this is what happened in stretch reflex. Okay, now you can think about this stretch reflex in real life as well. For example, if you, so now it's this example of your arm. Okay, if someone put the load on your hand, okay, put the load on your hand, you sometimes if they like throw it in, right? If they solely put it and you like intentionally accept it, it's more like voluntary, right? But somehow if they just like throw the load in your hand, like throw the ball in your hand, what would be your reaction? Like someone throw a bottle of water to you would just catch it, right? So you would like, hold that load automatically without thinking sometimes, right? So what happened here is that let's imagine like the first load when it pushed to your hand, right? When the first load is pushed to your hand, the load's pulling your hand down, right? When the load is pulling your hand down, it stretch this muscle right here, right? So when this muscle is stretched, similar thing happen, right? Stretch reflex. So it's gonna activate the muscle spindle. So muscle spindle detect the change of the length of the muscle, right? So whenever the muscle stretch, muscle spindle will be activated, okay? And then similar idea, it will send the signal through sensory neuron to the spinal cord, right? And then in the spinal cord, it's gonna activate the motor neurons that come back to the same muscle to make it contract, right? As a result, your muscle is contract. So now you can, hold that load because this muscle is now contract, right? But the first activation is the stretch, right? Stretching from this load, it's pulling your hand down, you stretch the muscle spindle is activated, send a signal here, motor neuron is activated, and then it stimulates contractions of exact same muscle, and then you respond by, contracting this muscle and then lifting your arms, okay? So that's just one example, okay? Stretch reflex. Now, another type of reflex, Golgi tendon reflex, is almost opposite of the previous reflex, and that's why we call inverse myotactic reflex. Myotactic reflex, by the way, it's another name for stretch reflex, okay? How does it work and how does it opposite? So in this case, imagine same idea. If you now after the previous example, right? Now you can hold a load. But imagine if someone intentionally put more load to you, like put on top of this load, like more and more and more, right? So what you want to do is like, okay, in the beginning, you want to try to hold that load as much as possible. But at the end, if that load is too much that you can handle, you will eventually release that load, right? To protect your muscle. And sometimes you release that load without even knowing, right? It's like, oh, I can't do this anymore. Even though you try, and then boom, you just have to release it, right? Those are the result from Golgi tendon reflex. So let's see how does it work, right? So in this case, the load, it's continuous event, right? So now you intentionally contract this muscle. Imagine previously this muscle is contract, right? Right here. So this muscle is contract very strong. The more load that you put in, the stronger the contractions will be, okay? Once that happens, the contractions of this muscle will stimulate the Golgi tendon organ. Okay, so Golgi tendon organ, if you remember, it's located in between muscle and tendon. Okay, it's like dense network that have, neurons, small neurons wrapping around together called Golgi tendon organ. Okay, and these receptors or these Golgi tendon organ is activated by the force. That means if you change the muscle length just a little bit, if your muscle contract just a little bit, then you're not going to activate the Golgi tendon organ. But if the muscle contract until one point, is we will develop a lot of force, right, to these structures right here. In that case, Golgi tendon organ will start to be activated, okay, when the muscle contractions is too much. And once it's activated, it's going to send a signal through the sensory neurons to the spinal cord, same thing. However, one different thing is that instead of stimulating the motor neuron that come back to the same muscle. This is the keyword, okay? Same muscle. Instead of directly activate the motor neuron that come back to the same muscle, like in the previous case, right? In the stretch reflex. In this case, it's synapse to interneurons, to inhibitory interneurons, okay? And that's why once this inhibitory interneuron is activated, the motor neurons can function. So no more signal coming into this muscle. So this muscle is now relaxed, okay? Once it's relaxed, then, you don't contract your arm, you don't lift your arm anymore, so you basically release the load, okay? So this Golgi tendon reflex is quite important to prevent the muscle from getting injured, right? Imagine if you voluntary control, right? Okay, I have to show that I'm strong. And then you keep holding the load again and again and again. Your muscle contractions will lead to muscle injury eventually, right? So to prevent that, your body has the protective mechanism, Golgi tendon reflex, to prevent the muscle from injury. Okay, so this is just one example, clear example to see the difference between stretch reflex and Golgi tendon reflex. Okay. Now, last example of the reflex, and this is also happening a lot, is the flexion reflex or withdrawal reflex. And as its name, right, flexion is involved in flexing either your arm away from the danger, or the painful signaling, or leg, or flex your leg away from the painful signal, right? Or withdraw your limbs away from those signals. And in this case, it makes sense, right? So you withdraw from what? From the pain or from whatever noxious stimuli. So the receptor in this case is nociceptor or pain receptor, right? In this case, for example, it's the nail. You step on the nail on the floor, right? So you won't spend time thinking like, oh, it's so painful. Let's move my toe, let's move my feet away from the nail, right? You don't think, you just lift your leg away, right? Because it's painful, like you didn't even think about it. So that's the quick reflex, right? So what happened there? In this reflex, you have the, again, receptor, which is cutaneous receptor, or more specifically, pain receptor, right? And then the pain receptor send the signal through sensory neurons again, right? Into the spinal cord. Now you can see, there are several interneurons, right? Right here in the spinal cord. So this reflex is quite complex that involves so many other neurons, okay? So the red neurons now here, what kind of red neurons here? These are all
Lower motor.
Yeah, these are motor neurons, right? So the motor neurons that go to this muscle, motor neuron that go to this muscle, or this muscle. Okay, so different motor neurons. So now there are 4 muscles right here. Which one are you going to activate? Which one you going to inhibit, right? So we know already from previous example, if you want to flex one, if you want to contract one, the other one, the opposite one, should be relaxed, right? So in this case, you want to activate the flexor muscle so you can flex your leg away from the painful stimulus, right? The extensor or the opposite muscle now have to be relaxed or has to be inhibited, right? So how do you do that? Again, through the interneurons in the spinal cord, right? So if you look at these neurons right here, purple is excitatory or inhibitory. Neuron in purple. If you just look
Is
at
excitatory.
exactly, so it's excitatory, right? So that's why when you excite with the sensory neuron, sensory signal, you excite, and then excite the motor neurons, okay? In contrast, the black right here is inhibitory interneurons, right? So whenever you reach the inhibitory interneurons, it's going to inhibit the neurons after that. In this case, it's the motor neurons that go to the opposite muscle or extensor right here, right? On the leg that is flexed, right? Now, very interesting thing. Imagine when you flick one leg away from the pin, for example, what do you do with another leg? Can you flex it? What do you do with another leg? When that
You need to try and stand still.
exactly, right? So you need to stabilize it, right? So it's basically you stimulate the extensor, right? And you inhibit the flexor. Because imagine if you stimulate the flexor, both legs are flexed, then you will fall, right? So, and the result can be worse than just a step on the, the pin, right? And you don't want that to happen. So in this type of reflex, there are the response on the other side called crossed extension reflex. Okay, that means the opposite limb, the other limbs, will be extended. Okay, so you're going to stimulate the extensor muscle and then inhibit the flexor muscle. So basically, inhibit the flexion. How do you do that? Same idea, excite, and excite here in this case, right? And then you excite the extensor muscle. And then here you have inhibitory neurons that inhibit flexor muscle. Okay. So this is another example of, the response of movement, the movement without the signal from the brain, right? Without the thinking command, right? Of course, another branch of the sensory neurons, so you have the nociceptors, right? And then you have the sensory neurons right here. Part of it come to the spinal cord to perform the reflex movement. And another branch, you can imagine, go up to the brain, right? And deliver the pain sensation, right? Because you feel pain also, okay? Even though you respond before that, but you almost at the same time because it's so everything happens so fast, right? So you feel pain as well, right? So, all right. So now I hope you get an idea of reflex arc, right? Reflex arc or reflex circle, which include again receptors, right? Sensory receptors, sensory neurons, right? The motor neurons, okay? And then the affected muscle, okay? So those are component of the reflex, okay? Now, if you look at this circuit again, just to emphasize, again, you have these receptors, you have sensory neurons, you have motor neurons, and you have the muscle, okay? If you have any kind of damage in the motor neurons, okay, one component of the reflex arc, right? So lower motor neurons in this case, right? Because it's coming out from the spinal cord, right? If it's damaged, what's going to happen to the reflex? Stronger, weaker?
Weaker reflex.
Weaker reflex, exactly, right? Or maybe you will not have reflex at all, right? Because this is a component of the reflex, right? So that's a good example. If you have problems with the lower motor neurons, usually when you test the reflex will be lower than usual, okay? Will be weaker or not happening at all, right? Now, another thing that actually influence the strength of the reflex. So I emphasize on the word strength of the reflex, okay? So you also have signal from upper motor neurons. And anyone remember where upper motor neurons comes from?
From the brain.
From the brain, right? So even though the brain doesn't command when reflex occur, it also help controlling strength of the reflex, okay? And usually most of the signal that comes from the brain to the reflex will inhibit the strength of the reflex. That means it regulates the strength of the reflex not to happen too strong, okay? For example, without the signal from the brain, when you do this knee jerk, you probably kick the leg like super strong, right? But in normal situation, you have some kind of control from the upper motor neurons or from the brains that kind of calming down or inhibit the strength of this knee jerk. So you respond in a normal range. Okay, so that's another important idea. Now, questions, if you have the lesion on the upper motor neurons, for example, if you have stroke or brain injury in the motor areas of the brain, what's gonna happen to the reflex? Stronger or weaker?
I think we, I think we will have stronger reflex.
Yes, right? Because in normal situation, it help slow down or weaker, inhibiting the strength of the reflex, right? So if without this inhibitory signal, then the reflex will become really strong. Okay, so I'll show the example in this case, right? And then I will ask you what's happening with this patient. Okay, so let's look at.
Hyperreflexia can be demonstrated in the patellar reflex. In this case, the patient has suffered a stroke affecting the left side of the brain. The patellar tendon extends from below the patella, which is right here. It's a broad band of tissue. It's easily palpable. If you're not sure where it is, have the patient extend their leg, which will cause the tendon to shorten. And you can strike directly on the tendon. Those reflexes are very brisk. And in fact, there are a few extra beats of movement, which are referred to as clonus. Again, classic for an upper motor neuron syndrome. In cases like this, the reflex can be elicited by simply tapping on the tendon often. You see, the same reflex requires very...
Okay, so what happened here? Anyone?
He has damage on the upper motor neuron, so he has a stronger reflex.
Right. So the reflex seems to be very strong, right? So you see, even using, even the physician used the finger to tap, he already responds like super strong, right? And so he's testing his right leg, right? Can you guess what part of the brains that are having problems?
The upper motor
Upper
neuron.
motor neurons, right? It can be, you can say that it's probably definitely the left part, right? Somewhere in the left part, because, one side of the um brain send a signal to another side of the body, right? So we haven't talked about it yet, but similar idea to somatosensory, right? But yeah, so in this case, the patient is having problems on his left brain. Okay, that's why the upper motor neuron cannot send a signal to inhibit the strength of the reflex. Therefore, the reflex happen very strong. Okay, when the reflex happens stronger than usual, we call that hyperreflexia. Okay, hyperreflexia, right? In contrast, if you have the weaker reflex, that is called hypo, right? Hyporeflexia. In this case, it's hyperreflexia, okay? Oh, it's in the slides actually. So yeah, so again, in summary, you have the reflex arc, right? So this is just the reflex. You have stimulus, receptors, and then you have the sensory neurons go to the spinal cord, motor neurons coming out, and then stimulate contractions in this case, right? That's the reflex arc. But in the same times, you have the control from the upper motor neuron to control the strength of the reflex, right? If you have the problems with lower motor neurons, any lesion of lower motor neurons, this reflex arc is not complete, right? So as a result, you have hyporeflexia, or worst case, areflexia, no reflex at all, okay? Because the component is not complete. In contrast, if you have problems in, either the tracts from the upper motor neurons or in the brain motor cortex itself, the motor area itself, then you don't have enough signal to control that strength, right? So the reflex becomes super strong. You can call that hyperreflexia, right? Or it can come in several other forms, also streamer plasticity or clasp knife reflex. I'll show you in a moment. Yeah. So this reflex is called clasp. Anyone know the word clasp knife? You can Google and then look at the image if you don't know, if you have no idea what is clasp knife, right? It's a type of the pocket knife, right? When you collapse, when you try to keep it, you have to put a little bit of pressure, right? And in the beginning, it has a little bit of resistance. And until one point, it kind of like collapse. It's kind of like boop, right? And then you can close that knife. So this is exactly the same as the response from these patients. And it's one example of hyperreflexia as well, problem with the upper motor neurons.
Any?
Right? So you can see that in the beginning, it seems to be like a very, the normal people will just, bend the knee easily, right? But the patient seems to have very strong resistance in the beginning, right? Until at one point, it's, the pressure is so high that it's collapse, right? So hyperreflexia, okay? So those are some example for reflex, okay? And see how many we have. Okay, let's take a little break before we come back to talk about voluntary movement, okay? Let's do now it's 8:25. Hey, 8:21. Let's come back 8:35. Okay? And if you have any questions, type it in the chat, right? I'll see you at 8:35. All right. So, okay, I got one question about the class 9 reflex. So basically, the first thing that happened in the class 9 reflex patients is the spasticity. Spasm, muscle spasm, right? So the contractions of the muscles are very strong in those patients, right? So that's why in the beginning, when the doctor tried to bend the knee, it's developed very high resistance, okay? And you can imagine it's very high resistance, very strong contractions. At the end, the collapse is a result from the Golgi tendon, okay? So it's basically when it reached to one point, it's released that resistance. So that's why it's kind of collapse quickly. But the problems you can see in the beginning, because usually if you test this in normal situations, in normal individual, you would just, respond easily, right? You just bend the knee easily according to the pressure that the doctor puts. But in this case, because they have very high resistance in the beginning because of the upper motor neurons problems. So when they test it, that's why it's developed, very strong movement like claps actions. Okay. So, right, so if you did not get that idea of like upper motor neurons, lower motor neurons lesions, so make sure you go back and then look at that, okay? And then hyporeflexia. Now, voluntary movement is another kind of movement that is more complicated, right? Again, in the reflex, you only have receptors, sensory neurons, motor neurons, and muscle. But in this case, you have so many other areas in the brain that are involved with voluntary movement, right? Starting with first idea development, right? Voluntary, as its name, you need to know what you want to do, right? You want to move your finger, you want to move your leg or your arms, right? And those ideas are developed in mostly prefrontal cortex, right? The frontal area of your brain. Basically, determines what you want to do, right? It's the area of thinking, which we spend, one lectures on that. The planning, the making, decision making, those kind of areas, those kind of things that are on this area, right? So that's the idea development. And then there's an area that involved with planning the movement. And this is very interesting because the actual movement is controlled. It's starting in the motor cortex, right? So there is a set of neurons in the motor cortex that will send the axon down to the spinal cord and then the muscle, right? That we talked about it already. So this arrow here is the simplify of upper motor neuron from the motor cortex down to spinal cord and then to the muscle and then create the movement. Okay, so this is like a short, summarize that we just talked about. Motor cortex down to movement, right? But before that, in reality, before the motor cortex can send those signals through the upper motor neurons, there are actually so many other areas involved in planning, meaning that these areas, including basal nuclei, cortical association areas, cortical association motor areas, and cerebellum will help with the planning of the movement, meaning it will determine which areas of the motor cortex to be activated and how strong of the signal, how long is the signal that the motor cortex has to send down to the spinal cord. Okay, so those are very important part of planning. You might have heard sometime, even before the actual movement, when you think about movement, okay, when they test, they look at the brain of the individual who are thinking about, jumping or running. The brain, especially the cortical association areas are actually active even before you make a move. Okay, so this is because you already plan the area of the brains that will activate the specific muscle. Okay. Basal nuclei and cerebellum also will help with smooth movement, right? And then you will see a lot of things, a lot of arrow happen here. So after the planning, you initiate the movement, motor cortex send the signal down to spinal cord, and then executive, right? Or make a move. In the same time, the blue arrows right here are the feedback control that go back to the motor cortex. Anyone know what's going on here in the feedback? How the body give the feedback back to the motor cortex? Any guess?
They go through the sensory upper neuron.
Yeah, remember the proprioceptor, right? Those receptors in the muscle, in the joint, in the tendon, right? Those receptors will send the signal back through the sensory neurons, and then there are connections between those and then back to the motor cortex to adjust the level of the strength, how much the motor cortex have to adjust. Is it too much contractions? Is it too less contraction, for example? Okay, so this is a very important feedback. That's why you can have, normal amount of balance. If you just want to walk, probably not a lot of, contractions, right? If you want to jump, you need more muscle, you need a lot of contractions, right? In one, in the leg. So you need contractions of more muscle and stronger contractions, for example. So those will be both the idea, the planning, and the feedback. Okay. So this is what happened in the voluntary movement. Okay. Now zoom into the motor cortex a little bit, right? So now the motor cortex is similar. If you cut, let's say if the big area right here, it's like one of the big, I think the picture in the overview will be like the best picture to see those, biggest central groove or central sulcus. So you can see the area in the front, it's the motor cortex, and area in the back, it's somatosensory cortex. In this case, this area, motor cortex, right? So similar idea to the previous, somatosensory cortex. If you cut it, you open it, there's also a map, right? And again, hands are so big, fingers are big, right? Areas that are responsible for hands are quite big, but for elbow, not that much, right? And as one of you answered in the beginning, it's big here because you have a lot of movements, fine movement for your hands and fingers, right? You can play piano with fingers, right? You don't play with elbow, right? So a lot of controls in this case, okay? And so the general idea when we talk about, the neurons from the brain, we emphasize on one major track right here, right? So you have the motor cortex, right? Any neurons that come from these areas down to specific muscle in your body, right? So those are, motor cortex, right? And those areas will send the axon down to the spinal cord, right? And then from the spinal cord, so these long motor neurons right here is the upper motor neurons, right? And from the spinal cord, you have another motor neurons, which is lower motor neurons, right? Coming out and then control the target muscle, okay? So this is major tracks for motor neurons. And these tracks, since it starts from the cortex and it goes down to the spinal cord, it is called corticospinal tract. Okay. And this is the only tract here that I want you guys to know in this level, right? Because in reality, there are so many other tracks, right? And those will involve a lot of anatomy, as some of you might know. But in this case, just know the major tracks from the motor cortex down to the spinal cord, corticospinal tracts, okay? One of the major tracks that, of the upper motor neurons. Now, Other tracks, just to, show you a little bit, there are some tracks that go from motor cortex and go to brainstem first, right? And then from the brainstems, there are another tracks coming down and it's named differently, okay? Depending on what regions of the brainstems, okay? So keep in mind, in reality, movement, how can you move nowadays, if in everyday life, those smooth movement involved in so many important tracks, okay? All right, so and for those cortical spinal tracks, that is it's quite important, because if you think about it, if you have the injury, in any of the one of these tracks, right, or injury in the brain in the motor area, let's say, patient come with the accident and then they break the skull fracture, and then they bleed in one of these motor areas, right? So that means, these upper motor neurons will have, some problems, right? So how do you test that? The patients come to the hospital sometimes unconscious, right? Unconscious. If you do deep tendon reflex, what do you expect? If you do deep tendon reflex or knee jerk, if the patients have, let's say, brain injury on part of the motor cortex, and then, you do the knee jerk, what do you expect to see? Hypo or hyper reflexia?
Hyper reflex.
Hyperreflexia, right? But the problem is that if the patients are unconscious, right, they are like lie down on the emergency bed, how you're not gonna kind of like wake them up, and then, deep tendon reflex is not um easy to do so, right? So one of the tests that can also be a quick test, especially in the ER, you see first thing when the patients come in unconscious, lying on the bed, and then like, have some accident, come into the hospital. This is called the Babinski test, okay? So the test is also to detect whether there's any damage on the upper motor neurons. More specifically, those cortical spinal tracts or pathway that we just talked about, okay? So the way that you test is you basically use the object to stroke from the sole of the foot, right here, to the top of the foot right here in these directions. And then normal response will be the flexing, like this, toe down, right? Flex. But the abnormal response will be the fanning of the toe, okay? Whenever you have this fanning up of the toe right here, the response is called Babinski sign, okay? So in normal people, you should not have any Babinski sign, right? So that means you should not respond like this. When you do these tests, you should respond like this, okay? You can test this with, your friends as well. I don't know if you have tried any of this before, but you can try and you should get some kind of response like this, right? You can't really do it to yourself, okay? It's probably just tickling sensation if you do it to yourself. Or sometimes if you put the pressure not hard enough, then you can have the tickling, feeling sensation, feeling tickling instead. So just like approximate pressure here, okay? Now, I'll show example of this one. So this is the same patients. Remember, these patients have the injury on the left brain. So what would you expect here? Anyone? If you do Babinski test,
The toe fanning
exactly. On which leg?
on the right leg.
On the right leg, right? So let's see.
The Babinski response in the setting of upper neuron dysfunction, as is the case with this patient, the patient suffered a left side, a stroke affecting the left side of the brain. The stimulus is applied to the lateral aspect of the foot and then across the balls of the toes. The Babinski response, if present, the great toe will flex and the small toes will fan out, which is exactly what happened here. One more time. And say the Babinski's response is present.
Right. So this is called Babinski sign, right? Or Babinski's response. So you can see this is the normal size, by the way.
Lateral aspect of the foot and across the toes.
Right. So you see a little flake, right? You see a little flakes. I forgot to continue the video on the knee jerk, like on the normal side, but it's like pretty soft, right? So hope you see the difference. Okay. So same thing, right? So now the test for reflex, that's why we spend some time, because it's quite useful for neurological examinations. Okay, it's underlying normal, response in everyday life. And actually, one thing I forgot a little bit, go back a little bit to the reflex here. The flexion reflex right here. It's not only important for removing your leg away from the painful stimulus. This kind of reflex is actually responsible for walking, normal pattern of walking. Okay, so you can imagine, like, you step on the toe, left and right as a rhythm. That's kind of like basic underlying mechanism of walking. Okay, not exactly the same, but similar idea. Okay, so back to the test. So those are the tests that we can do, the clinical test, right? So we talk about the class 9 reflex for upper motor neurons damage. We have stretch reflex. We can do, again, the knee jerk, or bicep or tricep as well. So if you see stronger response or hyperreflexia, that's an indicator for upper motor neurons lesions, right? Babinski sign, if you see the sign, let's say usually it's like positive sign, that means again, cortical spinal tract or upper motor neurons, right, are having problem. Strength testing is testing, whether you have like problem with the muscle or lower motor neurons, right? Because those are important for having, normal strength, also muscle tone as well. Okay. Now, another, not only upper motor neuron, lower motor neurons. I mentioned cerebellum too, right? Cerebellum is also have complex connections to those motor pathway. Okay, but the key concept, general idea, is that cerebellum, or another name, it's called little brain. Okay, control rate and range and force and directions of the movement. Okay, basically to make sure that the movement is smooth. Okay, it's smooth and it's going to the direction that you want, basically. And so when the cerebellum, when you have problems with the cerebellum, so many things can happen. You can still make a move. You can still make a movement, move your arm, move your leg, move your body, but the movement will not be smooth. Okay. And another name, you can see this word, the term ataxia can also develop, or intention tremor is the sign when the cerebellum is having problems or injured or some lesions. Okay, so this is example.
Put the pen on the cap on the pen. Okay. And I'm gonna hold the cap out here. You can put the pen on. Okay. The other side, same thing. Then put the cap on the pen. And now just go from the tip of your nose to the tip of the pen, back and forth. I'm going to move the pen. Okay. Another hand.
Okay, so anyone can explain what happened here? What do you see?
Um, she can still move, but it's not very precise in the
Exactly. Right, so it's not smooth, right? And especially when she is about to start and when she's about to stop. So start to stop. So this is like a key signs of the cerebral problems, or specifically called intention tremors. Okay, there are so many other signs as well, but this is one of the unique sign. Okay, and this test is called finger to nose test, right? So sometimes instead of using a pen, the physician can use finger, right? And then ask the patient to move from his finger to her nose and then back and forth, right? And then to see. Normal, you can test it to yourself, right? Or with your friends, moving from your nose and then to some of the other objects, and then see, if it's moved easily, right? It should be, okay. All right, so last component that we will mention is basal ganglia, okay. There are several regions of the brain that are located in the basal ganglia or basal nuclei, right? Sometimes when you call basal nuclei is the terms, because the nuclei mean the cell bodies of different neurons are stick together, right? The cell bodies of the neurons are stay together in the groups, so you call that area the nuclei. So sometimes you call basal nuclei or basal ganglia. So those nuclei include, all of these colored area right here, caudate nucleus, putamen, globus pallidus. So you don't have to remember these names. Again, we don't emphasize too much on anatomy here, but we are familiar, right, with the term basal ganglia, right? And anyone know that what neurotransmitter is used in the basal ganglia? Any previous knowledge, or anyone know? Okay, maybe you will know that problems with the basal ganglia can cause Parkinson's disease. Okay, anyone know what's the name of neurotransmitter that is used in this basal ganglia? And if you're missing that neurotransmitter, you can have Parkinson's disease. Anyone? Have you heard of dopamine? Dopamine. Anyone?
yes.
Okay, so dopamine is a major neurotransmitter that used in basal ganglia. Okay, so now we talk about acetylcholine, right, in the muscle, right? Acetylcholine can also be found in some part of the brain as well, right? But in the basal ganglia, the major neurotransmitter is dopamine. Okay, and the area here, if you look at these pictures, a part of basal ganglia that produced dopamine is this little guy right here called substantia nigra. Okay, so substantia nigra will be the regions that produce dopamine, and it will send dopamine to other areas in the basal ganglia. Okay, and these basal ganglia control planning of the movement. Okay, planning and execution of the movement. Make sure that the movement is again smooth. In simple word, it makes sure that when you move smoothly. When you don't move, the muscle stop. Okay, so there's no activity happen in the muscle. Okay, and when you move, then the muscle contract and everything. So make sure that the rhythm, everything is coordinating and going like smoothly. Okay, so you can imagine if the signal from the basal ganglia is missing, right? If you don't have enough dopamine, instead of muscle stop moving, sometimes when the patient just sit, the muscle move, okay, or shake, or the hand can shake or tremor, right? Resting tremor mean the muscle, involuntary small movement, right? When you did not, during the rest, right? When you did not make a move, okay? So that's the key sign for Parkinson disease. And the cause for Parkinson disease is actually unclear, but it's known better and better that, high level of free radical can damage this area of the brain and decrease the dopamine productions, especially those that result from, a lot of pesticide, using a lot of pesticide, insecticides. Those chemicals can create free radical and kill the neurons in this area. And for long term can cause Parkinson's disease. Another correlations that a lot of studies has been shown is those, sport that result in high impact to the brain. For example, kick, the kickboxer, the football player that has, a lot of impact again and again to their brains. Later in life, the chance to develop Parkinson's disease is also higher as well. Okay. Right. So this is a video showing resting tremor in Parkinson's disease. Okay. So normal patients, normal situations, the hand should not move at all, right? But in this case, the hands are moving during resting. And you can see the difference, right, between intention tremor and resting tremor. Intention tremor in case of cerebellar lesion, those tremor occur when the patient make a move, right? Make a movement. But in this case, it's rest at rest. Okay. All right, time for the quiz. Okay. If you're ready, I will post this in the chat. And okay. Oops. Just look at the link on top, okay? And I will open this for 5 minutes. Start. Anyone has problem accessing in the chat box? Okay, everyone gets it, right? If anyone has problem accessing the quiz, tell me now, okay? Because if you email me later, I won't accept any further answer, okay? So after we have 1 minute, about 1.5 minutes left, and after this, I'm gonna close the quiz. So no more response, okay? And if you email me later after this, then I won't open it again. So if you can't access it, let me know now. Okay. So we will do this and every day from now, and it will be a part of 10% attendance. Okay, time's up. All right, I'm closing the quiz now. All right, let's continue. Okay, so next system that we will talk about is the special sensory system. Okay, again, it's another sensory system, but as its name, special, and we will see how special it is. So recall a little bit when we talk about action potential, right? So during resting, you have the membrane potential negative 60 approximately, right? Depending on what kind of cells, neurons. And so when the stimulus appear, it will increase the membrane potential. And when it's reached the threshold, when the membrane potential reached the threshold, it will open. Anyone remember what channel that caused depolarization? What ion caused depolarization?
Sodium.
Sodium, right? Sodium channel, the flow, the influx of sodium inside the cell causing depolarizations, right? And then after that, what caused repolarization?
Potassium.
Right? Flowing the outflux of potassium, right? So potassium going out from the cells, right? But what caused the beginning, right here? What caused the increase of the membrane potential in the beginning, right? This is depending on the neurons, okay? So in case of synaptic transmission, if you have direct connection from one neuron to another neurons, okay, those receptors on neurons, the neurotransmitter that bind to the receptors on the neurons, can open the channel, right, and increase the membrane potential, right? And then eventually, once it reaches the threshold, you open the voltage gated sodium channel, right? Or on the skin, it can be mechanical gated sodium channel on your skin, right? And so when the pressure when someone touch on your skin, the stretch change the conformation or the shape of the receptor, opening that receptor and allow sodium to flow in, right? So a little bit of sodium flowing in, increasing membrane potential and making it reach the threshold. And then once it's reached the threshold, voltage gated sodium channel can then open. Okay. So here there's different mechanisms, right? Here, all the axons will be the same, right? At the axon hinlock, you have voltage gated sodium channel. Okay. But here can be different depending on neurons. Okay. Now for the special sensory receptors, those mechanisms can also be different as well. Okay, and we will talk about that a little bit. So you will see that I mentioned that, oh, this cause depolarization, this receptor, this, chemical cause depolarization. It's these depolarizations right here. Okay. All right. So we talk about somatosensory receptor already, right? That we have receptors on skin, either for pressure, temperature, chemical, right? If it's chemical, we call it chemoreceptor. If it's pressure, we call mechanoreceptor. Temperature, we call it thermoreceptors. Proprioceptors also, right? The receptors in a muscle, in joint, in tendon. Those are mechanoreceptors, right? For the special sense, for the light, you have what called, anyone? Photoreceptors, right? For the light. Sound, what kind of receptor? Anyone? What types of receptors that detect the sound?
Auditory.
Okay. Yeah, well, you use the auditory system, right? But more specifically, those receptors that detect the sound is actually mechanoreceptors, okay? Because the stimulus come from the frequency, right? The vibrations of the air, and then it create pressure that stimulate the mechanoreceptor inside your ear, right? So that's amazing. What about smell? What kind of receptors?
Chemical receptor.
Yeah, exactly. Chemoreceptors. Test?
Also chemoreceptor.
Yes, also chemoreceptor. Very good. So see, different kinds, right? So same idea. When you have stimulus, you activate the sensory receptor and you cause cell depolarizations, okay? Until it reach the threshold, then you can create action potential. Then when the action potential occur, those become the nerve signal, right? That can propagate through the nerve pathway and then arrive in the brain, okay? So this is a summary of the whole overall how it works. So start with the ear, okay? The ear, more complicated one. Very important, right? Sound. How do you detect the sound? So this is basic structure of the ear. You have the outer ear, which you have the auditory canal, right? Anything about hearing is auditory, right? So auditory canal, right? And then you have the tympanic membrane, right? Separate between the outer ear and middle ear. What's in the middle ear? Three pieces of bones, okay? So we have incus, malleus, and then you have the stapes, right? So you need to memorize the name, but just to know, like three little pieces of bone. These are the smallest bone in your body, right? It's very tiny, but very important. Now, last piece of bones is connected to the inner ear, okay? The inner ears are amazing structures right here, composed of two components, okay? These components right here are called semicircular canals. Okay, there are 3 canals right here. We'll zoom in a little bit, but just to show you the whole picture is right here. So first component, the semicircular canal. And you also have these light right here, which called cochlea. Okay, cochlea. Okay, the part of the inner ear that are important for hearing, is the cochlea. Okay, and you can imagine because it's directly connect to this last piece of the bones in the middle ear, right? So the frequency will come here and then continue and send it inside this cochlea right here. Okay, the top part right here, semicircular canal, play a role in balance, regulating balance, okay, which we'll also talk about it as well, okay. Now you can see that there are nerves that are coming out from the inner ear, right? So the nerve that come out from the cochlea is the cochlear nerve, right? And there are nerves that are coming out from these areas. These areas together, the area that control balance, we also call it vestibular, okay, vestibular area. So that's why we have the vestibular nerve that are coming out from these, semicircular canals in these areas here. Together, it's combined into big bundle called vestibulocochlear nerve. Okay, so just these 2 nerves come together and travel to the brain. Okay, so this is a basic structures, right? And again, this is zoom in. So we have basically two parts or 2 apparatus. The one that play a role in hearing or auditory is on this side, right? Cochlea right here. And vestibular apparatus, right? Which is the 3 semicircular canal playing a role in balance, okay? Now for hearing, again, you have the vibrations, you have the sound that are coming in, right? And it depends, the sound, different kind of sound, it's just different frequency, right? Some of sound have high frequency. Some, high noise is like high frequency. So low noise is like low pitch is like low frequency, for example. So that's why your ear can detect different frequency. So when those frequency come in, it causes the vibrations, right? It's the frequency, it's the checking of the air, and then it causes vibration of this tympanic membrane. And then it delivers that vibrations into the bones, right? The bone is conduct, right? Conduct, very important for conduction. Conduct that vibrations to the inner ear, okay? And then the inner ear, you have this cochlea, which is filled with fluid. So now you can imagine, shake, the air shake, and now the bone shake, and then now the fluid inside the inner ear is also shake as well, or move as well, okay? Then something happened inside this cochlea when the fluid moves and activate the nerve, then the nerve can send the signal through the brain area, which is on the side on the temporal lobe right here. Then you have the perception of the sound, okay? So let's zoom in to these auditory apparatus, okay? If you cut this cochlea, again, remember the name cochlea, okay? Cochlea play important roles in hearing. So if you cut this cochlea and then open, you see this cross section right here. Inside the cochlea, you have 3 chambers, okay? The most important chambers is like in the middle one right here, because it's the place where you have what called hair cells, okay? So the hair cells are located in the middle chamber right here. The bottom is the basal membrane. You can write it down in here, basal membrane or basilar membrane, okay? So the bottom of these cells. So what is hair cell exactly? Cells with the hair, right? So basically you can see that these cells has tiny structures that looks like the hair, right? Pointing upward, okay? And the hair of these cells are attached with the top membrane. So the top membrane is called tectorial membrane, okay? And it's acting like a roof, okay? And it's attached to the hairs, to the more specifically, these can be called cilia, right? This is basic cell biology. So cilia of the hair cells, okay? And then again, the bottom right here is basal or basilar membrane. Okay, now you can imagine if the basilar membrane, if this membrane move, if it's moved, it's gonna cause the hair cells to move too, and the hair or the cilia that are attached to the top membrane right here will move and will bend, right? So the bending of these hair cells or the cilia on the hair cells will cause the signal, okay? So zoom in here. So what happened is that when back in here, when you have the fluid fill inside and then the bone is kind of shaking, right? It will cause the fluid inside this move, right? And once the fluid move, it will also move the basilar membrane right here, okay? So no sound, the hair is attached, right, on the part of the, basilar membrane, and then the hair is attached to the tectorial membrane right here, right? But then when the basilar membrane moves, see, the hairs bend, right? These cilia bend, okay? What happened when the cilia bends? This is the key. On top of the cilia, you have channel, okay? Ion channel. And the ion channel here is the potassium channel, okay? So when the hair cell move and then the cilia bend, this channel will be open, okay? And again, remember it's mechanical gated or mechanoreceptors, right? Meaning that the movement of these will cause the change of the conformations, opening this channel, okay? Now, when the channel open, potassium will flow inside the hair cell, okay? Anyone detect something weird in here? When potassium channel opens, potassium flow inside. Is it common? Is it normal, like that the potassium will flow inside? What happened in the regular neurons when the potassium channel open?
The depolarization.
A what?
The depolarization.
Usually it repolarization, right? That means usually in the normal neurons, concentrations of potassium is higher inside or outside of the neurons.
Higher inside.
It's higher inside, right? So that's why in normal neurons, when you open the potassium channel, right, during the repolarization, potassium will leave the cells, right? It will go out because it's inside, it's higher than outside, right? But in this case, it's exception, okay? Because outside of these hair cell, more specifically within, this endolymph is the fluid that filled this cochlea, inside the cochlea is called endolymph. So in the endolymph, you have very high concentrations of potassium, okay? That's why in this case, when the potassium channel open, potassium will flow into the cell, okay? And in this case, it's the potassium that cause the depolarization of the hair cell, Okay, so this is the unique and exceptions. Okay, that's why it's called special sensory also, because the receptor is kind of special, right? It's the hair cells and it has some special mechanism. And once it's depolarized, right, it can then cause the opening of calcium channel. Calcium comes in, stimulate neurotransmitter release, and then activate the nerve. This nerve will then, this is the auditory, this is the nerve that will send and become the auditory nerve, sorry, and then send it to the brain. Okay, so summary, again, when you have sound wave, you have vibration of tympanic membrane, right? And then this is connect from outer ear and middle ear, right? And then the bone shake, the three bones shake, causing the vibrations, connect to the oval window, causing the fluid inside the cochlea to move. Then basilar membrane move, the cilia bend, right? Cilia bend, open the potassium channel. Potassium channel flow in and activate the cells, eventually cause the action potential in the auditory nerve. Okay, so this is like big picture summary, right? So you can see this is the hair cell that we're talking about, right? When you have the movement of basilar membrane, the hair cell bend, and this is activated, you activate the nerve. And where does the nerve go? The nerve will then, from the inner ear, right? It will go to, it's a cochlear nerve, which will combine with vestibular nerve, becoming vestibular cochlear nerve, and then go to the brainstem, go up into the brains, and then eventually reach the primary auditory areas, right? And again, another sensory neuron, sensory nerve that synapse in thalamus as well, okay? So final target here is auditory cortex, okay? So when the signal reach to auditory cortex, then you have the perception of the sound, okay? So this is the hearing part of the ear. Now you can, if you have problems with the ears, and major types of problems can be divided into conduction deafness or nerve deafness, okay? Conduction deafness, as its name, the problems with conduction. So the functions of the bones, right, in the middle ear, playing a very important role to conduct that signal into the inner ear. So if there are some problems here in the middle ear, for example, some infections right here, then you can disrupt these conductions, right? So defect in outer or middle ear, defect conduction. So you can have deafness for that. Or another category, if you have problems with the nerve right here, then either nerve damage or some brain tumor in the brain. So this is behind the conductions, right? In this case, it's nerve deafness. Okay, so these are two major types of deafness. And you can do this test to basically differentiate, right? So for air conduction and bone conductions. So usually for the air conduction questions, if you have air conduction is basically you use the vibration fork, and then you kind of put the fork on the air next to the ear, right? Nothing touch your bone. But for the bone conduction, you can kind of like bypass those conductions and then touch the vibration fork directly on the bone right here behind your ear, okay? Questions. If you have nerve deafness, you have the nerve damage. When you do this air conduction test, can the patient hear if the patient have nerve deafness?
No.
No, right? Because they don't have their nerve, the nerve has problems, right? So no sound. What about these tests? If they have nerve deafness, and if you do bone conduction, you shake the vibration fork and then you touch it here. And if the patients have problems with the nerve or with the brain, can they hear?
Still no.
Still no, exactly, right? So both tests will be, abnormal in the patients with nerve damage or nerve deafness, right? So that's one thing. But if, let's say, if the patients have conduction problems, okay, and you do air conduction here, can they hear for the conduction deafness or air conduction?
No.
No, right? Because they cannot do conductions. The bone is having problems, for example, right? But if you do it here, can they hear? If they have conduction deafness.
I think they can't hear.
Yes, they can, right? Because this case, you basically bypass the functions of those conductions, machinery, right? You don't need that bone to basically help deliver that frequency directly to the inner ear by going through the bone instead. Okay, so this is one way that you differentiate between the nerve deafness and conduction deafness. Okay, a little bit about the test, right? Okay, so keep going. Or maybe take like a short break because this one is a little heavy. Let's say like 10 minutes for this one before we come back. So we come back at 9:40. Let's do 9:45. So let's take a break a little bit, or in case some of you have questions as well. Okay. See you at 9:45. Okay, let's continue. All right. So again, before we talk about these areas, right? The cochlea. So when you have the sound frequency comes in, then you basically stimulate the movement of the fluid inside the cochlea, right? That fluid is called endolymph, and then inside the cochlea you have the hair cells that are located on the basilar membranes. And so whenever the fluids move, the endolymph move, those hair cells move, and then the cilia or the hair bend, opening potassium channel, potassium flow in, depolarize the hair cells, and then, cause further cause signal action potential that it travel in the auditory nerve to the brain. Okay. Now, the other part of the inner ear is doing totally different things. Okay. It's involved in the movement, detection of the movement of the head, right? And very important for controlling balance. Okay. So there are two parts that are included in the vestibular apparatus. The first parts are called semicircular canals. Okay, so those are these three ring right here, 1, 2, 3, right? Again, inside of these semicircular canals are also fluid field, right? Same thing, endolymph as well, okay? And at the end of these canals, you can see like a little bits of, swollen structures right here. This is called ampulla of semicircular canals, right? And this is the location where you will find the hair cells. Again, the hair cells is here, right? But just play different roles. Now that's the first part, semicircular canal, okay? Zoom inside this semicircular canal. Okay, so inside of these, especially these ampulla right here, you will see the structure, right? That's why it's kind of look like swollen a little bit because it has these big structures right here. So in this area, again, you have the hair cells, right? And then you have cilia of the hair cells, right? Or the hair, that just look like the hair. Those cilia are buried in the structure called cupula, right? So this cupula here is basically covered, those has those hair, and then again inside this semicircular canal you have the fluid, right? So it's filled with fluid. So you can imagine anytime you move your head in the angular motions, right? So this semicircular canal detect angular motion. So any motions of, you're turning your head sideways, you move your head up and down, right? Like nodding, for example, or you shake your head left and right, right? Towards your shoulder, right? Left and right, or you turn your head, to the left or turn your head to the right. Those kind of like different motions that you can make, right, on your head, angular motions. Whenever you move your head or you rotate your head, those liquid inside the semicircular canal will move, right? Those endolymph more specifically will move. And the movement of endolymph will bend these cupular structures. And then the bending of the cupular structures will cause the cilia to bend, right? So the hair cells or the cilia of the hair cells are bent. And then same things happen. Potassium channel. Every time the hair cell bend, there's potassium channel at the end of those hair cells. And those channel will be open and allowing potassium to flow inside the hair cell, depolarize this hair cell, and then activate the nerves, right? Sending the signal to the brain, telling brain that, okay, now you're making the angular movement or rotating your head, okay? That's the first structure, semicircular canal. Another structure is next to it. Okay, this structure is deep inside. It's called otolith organs. Okay, in general, it's called otolith organs. And more specifically, it composed of two parts, utricle and saccule. This region detect linear motion and head position. Okay, what does it mean? So the reason why it's called otolith organ is because, so instead of cupula, right? So in this area, this is the otolith organs deep inside, right? Instead of the cupula right here in the semicircular canal, in this case is the membrane, okay? It's a thin membrane that are filled with crystal, okay? And those crystal is more specifically calcium carbonate crystals, okay? Other name, we call this calcium carbonate crystal that are on the membranes. We call these otoliths, okay? The otoliths, or basically the stone, right, on this membrane. So otolith membrane and otolith, which is the crystal, okay? So you can imagine, like, every time that you know, accelerate, right? Let's say you imagine you are in a car and then the car move really fast, accelerate like immediately, or you put the brake immediately, your head did not actually move in, you know, angular motions, right? But you sense that gravity, right? So those gravity will cause this membrane, otolith membrane, to move, right? And same idea, when the otolith membrane move, you bend the cilia of the hair cells, right? Don't worry about the detail of the name. There are several types of the cilia, but in general, these cilia will bend. And the same idea, you open potassium channel come in and then activate, you know, these hair cells, and then you send a signal to the brains, telling the brain that, oh, these are the movement, right? The movement are occur, okay? Also, when you, let's say, when you see the head position is still stretched, right? In this case, you did not move your head, but you move the whole body, right? So you bend your body down to basically pick up the stuff. But when you bend down, the gravity also pull this otolith, right? Crystal is kind of heavy, right? So it pull the otolith down. And so it's caused the cilia to bend as well, because the membrane is pulled with the otolith and then the membrane is bent. And so it's going to stimulate, you know, depolarizations and a nerve signal to the brains, telling the brains that you're actually bending now and picking up, you know, something in this case, right? So this example, when you tilt your head, right, forward or backward, right, whenever there's gravity involved, right, it's going to pull these otolith membranes in whatever directions, right, and it's going to send a signal to the brain that you're moving forward or backward. Or when you do acceleration, you move very fast and then the gravity pulling this back, or you stop really fast and then gravity pulling these forwards, right? So these also create a movement of the otolith membrane and then cause the hair cells to bend as well, okay? So what happened here in both vestibular or in vestibular organ, right? Both semicircular canal and the otolith organ will then send a signal to vestibular nerve, right? And where do this nerve go? It will go into the vestibular nuclei, mainly in the brainstem, okay? And there are a lot of branches that can go from these nuclei. But one of the important branch go down to the spinal cord, okay? And when it go down to the spinal cord, can you guess what does it do when it goes down to the spinal cord? Signal from the ear go down to, why signal from the ear go down to the spinal cord? Can anyone guess?
So that they will go to the lower motor neuron and
Exactly. Exactly. So why do you need it to go? Why do you need signal from the ear to go to the lower motor neuron?
so that they can tell the muscles to move to balance.
Exactly.
Um,
Right, exactly. So in this case, for example, right? So if you bend yourself, you can test yourself, right? If you bend yourself to the front in this case, your muscle here need to know, right? So you basically send a signal to the spinal cord to make sure that you maintain the balance. Your spinal cord adjusts the contractions of the muscle. So the contraction of the muscle in this posture is not the same as this one anymore, right? So you have to put a little bit more force here in the front to make sure that you stabilize the pose, right? So in another word, the head movement, the position of your head, the balance, is adjusted by this, vestibular signal that comes to the brainstem and then send the signal down to spinal cord and then adjust the muscle contractions. Okay. So that is one very important way to maintain the body balance. Okay. I think I did went through pretty fast today, and we cover a bunch of things, and I think we still have time for next lecture for cover the rest. So I'm gonna keep this visual system and the test for next lecture, okay? But because I'm gonna ask you something, so we will stop early today. You will have about, let's say, 1 hour, okay? So I want to make sure, go back. I'm gonna pause the record. It's gonna take some time, maybe like 10 minutes to finish, making the video and everything. So after I finish, I'm gonna send email directly, okay? Including the previous lecture and today's lecture as well. So make sure that you review, okay, today's lecture more specifically. Make sure that you understand, the somatosensory system, right? In terms of what, receptors that you have in the somatosensory system. How does it involve, okay, what kind of, these three different receptors, how does it involve in the balance or movement, right? Make sure that you understand the concept of motor system, reflex, right? How does it work? Hyperreflexia, the diagnosis of that, Babinski sign, those kind of things that I mentioned today, that we learned today. The cerebellum, Parkinson's, what kind of tremors, those kind of things. And if you, also the functions of the inner ear, right? Hearings or balance, okay? If you don't understand anything, so this is a good time to ask questions now, or if you want to go back and then review, you can also, and then send me email as well. You can do that. Or so you can also discuss with your friends, because this information will be used for tomorrow's discussion. Okay. And again, tomorrow we will spend some time, maybe less than an hour, to finish, the rest of the special sensory system, vision, taste, and smell. And then after that, we will go into the small group activity. Okay? Any questions before you stop? I will stay for a little bit until make sure that, you don't have, because some of you might want to ask questions like personally. So I will stay a little bit, but any questions so far for now? Or about group assignment? Everyone is okay with the group assignments and everything? Can also be questions from last lecture as well. Okay. It's also good to review it when it's fresh, okay? Because if you remember, again, your final exam, the 60% will be on April 19, okay? And then the major part of the exams will be the content from last time's lecture and today's lecture. I can tell you that, okay? So make sure that today it's really basic information that I talked about. So some of you might know that very well, but it might be new for some of you. It might be too complicated for some of you, but don't let it pass by, okay? Ask questions if you don't get it, okay? All right, any questions?
Sorry.
Yeah.
I couldn't submit the attendance form on time because of my network problem. So, and I message you immediately right after the link got locked. So can you check my attendance
Okay.
today?
I will have to, when this happen, I will consider case by case, okay? As I mentioned, it's like, like 5 minutes. And so I will consider case by case, okay? I'll get back to you for that, all right? But so make sure next time, again, emphasize next time, if you have problems, say something right during that window of time, okay? Because sometimes if you contact me later, it can be like, oh, you're not there, but then you come back later or something, right? So I try to be like fair for everyone, okay? So but I will think about it case by case, okay?
So teacher, I have a problem. My house got a power outage. So can you reopen the link, or I can email you after?
Yeah, again, same thing, case by case, okay? Will contact me by email, all right? Any questions related to the content? Okay, group assignment. Group assignment, you will see tomorrow what to do in a group, okay? But what we're gonna do is we're gonna divide the Zoom into small rooms. And 5 or 6 of you will be in the groups, and I will give you questions, okay? And then your job as a group is to help each other to discuss and then come up with the reports. You will see tomorrow. It's hard to like explain without knowing the case and stuff like that, okay? Tomorrow, just prepare, just do what I said today. Everyone, not just one in the group, right? Because you will basically evaluate your friends in the group too, because everyone will get the same score, but everyone will have to help each other. So go back and then make sure you understand the content that we talk about today, okay? All right, so for those of you who cannot you know who missed the attendance, email me separately, okay? So because I cannot cache everything in the chat now, right? So just email me and then explain like what's going on, okay? All right, and then next time try to make sure that everything is okay. If you have problems, let me know during the quiz times, right? Not after, right? Okay, so if there's no questions, spend this time, we finish early, spend this time to review because it's important. Otherwise, tomorrow you come and then you will kind of like, oh, I have no idea. How comes, everyone else in my group can answer all those questions, but I have no idea. Okay, so spend this time to go back a little bit. I will, after this, I will stop the meeting and then make sure the video is paused by 10:30. Okay, so everyone can go and listen to the record again. And then again, if you have any questions, either email me or you can keep it for tomorrow. Okay. All right. See you tomorrow then. And again,
Bye.
yeah, question? Go ahead. Do you have a question?
No, there's no question.
Okay, all right.